Question 1. During cardiac arrest, what is the recommended compression depth for adults? A. At least 1 inch 2.5 centimeters. B. At least 1.5 inches 3.8 centimeters. C. At least 2 inches 5 centimeters but no more than 2.4 inches 6 centimeters. D. At least 2.4 inches 6 centimeters. Answer, C. At least 2 inches 5 centimeters but no more than 2.4 inches 6 centimeters. This question tests your knowledge of high-quality CPR components, specifically compression depth. The keywords recommended compression depth for adults highlight the specific guideline. Effective chest compressions are crucial because they create blood flow to the heart and brain. A depth of at least 2 inches 5 centimeters but no more than 2.4 inches 6 centimeters ensures optimal circulation without causing excessive injury. For example, pushing too shallow won't adequately circulate blood, while pushing too deep can cause complications. Always remember that proper depth, along with a rate of 100 to 120 compressions per minute and full chest recoil, are key for high-quality CPR. Question 2. A patient presents with symptomatic bradycardia. After ensuring airway, breathing, and circulation, what is the initial recommended pharmacological intervention? A. Adenosine. B. Amiodarone. C. Atropine. D. Epinephrine. Answer, C. Atropine. This question focuses on the initial management of symptomatic bradycardia within the ACLS algorithm. The key phrase, symptomatic bradycardia, indicates that the patient's slow heart rate is causing instability, e.g., hypotension, altered mental status, requiring immediate intervention. Atropine is the first-line medication for symptomatic bradycardia because it blocks the parasympathetic nervous system, which can increase heart rate. If atropine is ineffective, transcutaneous pacing or other medications like dopamine or epinephrine may be considered. Always start with atropine for symptomatic bradycardia if there are no contraindications. Question 3. What is the most appropriate initial energy dose for defibrillation of a patient in pulseless ventricular tachycardia, private, using a monophasic defibrillator? A. 120 J. B. 200 J. C. 300 J. D. 360 J. Answer, D. 360 J. This question evaluates your understanding of defibrillation energy settings for monophasic defibrillators in cardiac arrest. The keywords initial energy dose, pulseless ventricular tachycardia, private, and monophasic defibrillator are critical. For monophasic defibrillators, the recommended initial and subsequent energy dose for VF/private is 360 joules, as this fixed high dose has been shown to be effective. In contrast, biphasic defibrillators use lower, device-specific energy settings. Remember that 360 J is the standard for monophasic shocks in VF/private. Question 4. A patient in cardiac arrest has achieved return of spontaneous circulation, ROSC. What is the next immediate priority in post-cardiac arrest care? A. Begin therapeutic hypothermia. B. Perform a 12-lead ECG. C. Obtain an arterial blood gas. D. Optimize ventilation and oxygenation. Answer, D. Optimize ventilation and oxygenation. This question tests your knowledge of immediate priorities following return of spontaneous circulation, ROSC, in the post-cardiac arrest algorithm. The keyword immediate priority after ROSC guides you to the most critical initial stabilization steps. After ROSC, The primary goal is to optimize ventilation and oxygenation to prevent rearrest and minimize secondary brain injury by maintaining appropriate oxygen saturation and end-tidal CO2 levels. While a 12-lead ECG and therapeutic hypothermia are important, they follow the initial stabilization of airway, breathing, and circulation. Always stabilize the patient's breathing and oxygen levels immediately after ROSC. Question 5. What is the recommended dose of epinephrine for adult cardiac arrest? A. 0.5 mg 4/IO every 3 to 5 minutes. B. 1 mg 4/IO every 3 to 5 minutes. C. 1 mg 4/IO every 5 to 10 minutes. D. 2 mg 4/IO every 3 to 5 minutes. Answer: B. 1 mg 4/IO every 3 to 5 minutes. This question assesses your knowledge of key pharmacology in cardiac arrest. The critical terms are recommended dose of epinephrine and adult cardiac arrest. Epinephrine is a potent vasoconstrictor and cardiac stimulant, used in all cardiac arrest rhythms to increase coronary perfusion pressure and cerebral blood flow. The standard adult dose is 1 mg administered intravenously, 4, or intraosseously, IO, every 3 to 5 minutes during resuscitation efforts. Remember this specific dose and frequency, as it's a cornerstone of ACLS pharmacology in cardiac arrest. Question 6. What is the primary reason for administering adenosine in a patient with a stable narrow complex tachycardia? A. To increase blood pressure. B. To convert supraventricular tachycardia, SVT, to sinus rhythm. C. To slow ventricular response in atrial fibrillation. D. To treat symptomatic bradycardia. Answer: B. To convert supraventricular tachycardia, SVT, to sinus rhythm. This question explores the specific use of adenosine in tachycardia algorithms. The key terms are administering adenosine, stable narrow complex tachycardia, and primary reason. Adenosine works by temporarily blocking the AV node, which can interrupt the re-entry pathway responsible for most supraventricular tachycardias, SVT, allowing conversion back to sinus rhythm. It's a diagnostic and therapeutic tool for SVT, not typically used for blood pressure support or slowing atrial fibrillation. Think of adenosine as a chemical cardioversion for SVT. Question 7. A patient presents with signs and symptoms of acute coronary syndrome, ACS, and ST segment elevation on their 12-lead ECG. What is the immediate priority intervention? A. Administer intravenous fluids. B. Prepare for immediate revascularization, e.g., PCI or fibrinolysis. C. Administer amiodarone. D. Perform immediate defibrillation. Answer: B. Prepare for immediate revascularization, e.g., PCI or fibrinolysis. This question focuses on the critical initial management of ST elevation myocardial infarction, STEMI, within the ACS algorithm. The key elements are acute coronary syndrome, ACS, ST segment elevation on their 12-lead ECG, and immediate priority intervention. ST segment elevation indicates a complete blockage of a coronary artery, requiring urgent reperfusion to save heart muscle. While other interventions like oxygen and aspirin are important, immediate revascularization, either via percutaneous coronary intervention, PCI, or fibrinolysis, is the definitive and time-sensitive treatment. Remember that time is muscle in STEMI, making reperfusion the top priority. Question 8. How often should rescuers switch roles during high-quality CPR to prevent fatigue and maintain compression quality? A. Every 5 minutes. B. Every 3 minutes. C. approximately every 2 minutes or after 5 cycles. D. Only when one rescuer becomes exhausted. Answer, C. Approximately every 2 minutes or after 5 cycles. This question assesses your knowledge of optimizing CPR performance through team dynamics. The keywords switch roles, high-quality CPR, and prevent fatigue highlight the importance of maintaining effective compressions. Rescuer fatigue significantly reduces compression quality over time, so switching every 2 minutes or after 5 cycles, which is roughly 2 minutes at a rate of 100 to 120 compressions/minute, helps ensure continuous, high-quality chest compressions. Regular, planned role changes are essential for sustained, effective CPR. Question 9. What is the primary indication for using naloxone in an emergency? A. To treat opioid overdose. B. To reverse benzodiazepine overdose. C. To manage hyperglycemia. D. To treat acute asthma exacerbation. Answer, A. To treat opioid overdose. This question tests your understanding of a specific emergency medication and its primary use. The keywords primary indication and naloxone point directly to its life-saving purpose. Naloxone is an opioid antagonist, meaning it rapidly reverses the effects of opioid medications by blocking opioid receptors. It's crucial in situations of suspected opioid overdose, where respiratory depression is a major concern. Always consider naloxone for patients with respiratory depression and a history or suspicion of opioid use. Question 10. Which of the following is a common reversible cause of cardiac arrest, H's and T's? A. Hypertension. B. Hyperkalemia. C. Hyperglycemia. D. Hypernatremia. Answer, B. Hyperkalemia. This question directly tests your recall of the H's and T's, which are common reversible causes of cardiac arrest. The keyword reversible cause and the implied H's and T's framework are important clues. Hyperkalemia, excessively high potassium levels in the blood, is one of the critical H's that can lead to life-threatening arrhythmias and cardiac arrest. Recognizing and treating these reversible causes, such as hyperkalemia, hypovolemia, hypothermia, hypoxia, hydrogen ion, acidosis, toxins, tamponade, tension pneumothorax, and thrombosis, is vital for successful resuscitation. Question 11. What is the first priority when a patient is found unresponsive and appears to be in cardiac arrest? A. Obtain a 12-lead ECG. B. Start chest compressions immediately. C. Administer an intravenous fluid bolus. D. Defibrillate immediately. Answer, B. Start chest compressions immediately. This question focuses on the critical initial steps in managing a potential cardiac arrest. The keywords first priority and unresponsive and appears to be in cardiac arrest indicate the immediate need for action. The most crucial initial step is to begin high-quality chest compressions as soon as cardiac arrest is recognized to circulate blood to the brain and heart. While other steps like defibrillation or obtaining an ECG are important, they follow the initiation of chest compressions and activation of the emergency response system. Always prioritize pushing hard, pushing fast. Question 12. A patient experiences sudden onset of weakness on one side of their body, facial droop, and slurred speech. What is the most important initial action for the healthcare provider? A. Administer aspirin. B. Transport to the nearest hospital for a CT scan of the brain. C. Administer nitroglycerin. D. Perform a 12-lead ECG. Answer B. Transport to the nearest hospital for a CT scan of the brain. This question addresses the time-critical management of a suspected stroke. The symptoms, sudden onset of weakness on one side, facial droop, and slurred speech are classic signs of a stroke. The most important initial action is rapid transport to a stroke-ready hospital capable of performing an emergency CT scan of the brain, as this imaging is crucial to differentiate between ischemic and hemorrhagic stroke and guide treatment decisions. Timely assessment and transport are paramount in stroke care. Question 13. What is the recommended chest compression to ventilation ratio for a single rescuer performing CPR on an adult? A. 15:2. B. 30:2. C. 30:1. D. Continuous compressions. Answer B. 30:2. This question tests your knowledge of fundamental CPR guidelines for adults. The keywords recommended chest compression to ventilation ratio, single rescuer, and adult specify the scenario. For a single rescuer performing CPR on an adult, the guideline is 30 chest compressions followed by 2 ventilations. This ratio balances the need for effective circulation with adequate oxygenation. Always aim for 30 compressions for every 2 breaths when performing single rescuer adult CPR. Question 14. What is the maximum duration of an interruption in chest compressions during CPR? A. 5 seconds. B. 10 seconds. C. 15 seconds. D. 20 seconds. Answer B. 10 seconds. This question highlights a critical aspect of high-quality CPR, minimizing interruptions. The keyword maximum duration of an interruption emphasizes the importance of continuous compressions. Prolonged interruptions in chest compressions significantly reduce coronary and cerebral perfusion, negatively impacting outcomes. Therefore, rescuers should strive to keep any pauses in compressions to an absolute minimum, ideally no longer than 10 seconds, for interventions like rhythm analysis or defibrillation. Remember to stay on the chest as much as possible. Question 15. A patient is in ventricular fibrillation, VF. After 1 shock and 2 minutes of CPR, the rhythm remains VF. What is the next immediate intervention? A. Administer atropine. B. Administer 1 mg epinephrine. C. Perform synchronized cardioversion. D. Obtain a 12-lead ECG. Answer B. Administer 1 mg epinephrine. This question tests your progression through the adult cardiac arrest algorithm for shockable rhythms. The scenario describes ventricular fibrillation, VF, after 1 shock and 2 minutes of CPR, and rhythm remains VF, indicating a persistent shockable rhythm. According to the algorithm, if VF persists after the first shock and 2 minutes of CPR, the next immediate intervention is to deliver a second shock, followed by administration of epinephrine and continued CPR. Delivering epinephrine at this point helps to improve myocardial contractility and coronary perfusion. After the second shock, epinephrine is the next drug of choice. Question 16. Which of the following rhythms is typically treated with unsynchronized cardioversion, defibrillation, in an unstable patient? A. Sinus bradycardia. B. Atrial fibrillation with rapid ventricular response. C. Ventricular tachycardia with a pulse. D. Pulseless ventricular tachycardia, private. Answer D. Pulseless ventricular tachycardia, private. This question focuses on the appropriate use of defibrillation versus synchronized cardioversion based on rhythm and pulse presence. The key terms are unsynchronized cardioversion, defibrillation, and unstable patient. Defibrillation is used for chaotic, disorganized rhythms like ventricular fibrillation, VF, and pulseless ventricular tachycardia, private, where there is no coordinated electrical activity or pulse. Synchronized cardioversion, in contrast, is used for unstable tachycardias with a pulse, e.g., ventricular tachycardia with a pulse or atrial fibrillation with rapid ventricular response, to avoid shocking during the T wave, which could induce VF. If there's no pulse, it's a defibrillation scenario. Question 17. What is the primary function of a team leader during a resuscitation attempt? A. To perform chest compressions. B. To delegate tasks and make clinical decisions. C. To document all interventions. D. To administer medications. Answer: B. To delegate tasks and make clinical decisions. This question addresses the importance of effective team dynamics in resuscitation. The keyword primary function of a team leader highlights their critical role. The team leader is responsible for overseeing the entire resuscitation effort, ensuring all tasks are performed efficiently, delegating roles to other team members, and making critical clinical decisions based on assessment findings and algorithms. While other team members perform compressions, documentation, or medication administration, the leader coordinates the overall effort. A good team leader fosters clear communication and efficient care. Question 18. A patient has a suspected opioid overdose, is unresponsive, and has agonal breathing. What is the immediate priority? A. Administer activated charcoal. B. Call poison control. C. Administer naloxone. D. Support ventilation. Answer: D. Support ventilation. This question prioritizes airway and breathing management in a specific emergency scenario. The keywords are suspected opioid overdose, unresponsive, and agonal breathing, indicating severe respiratory depression. While naloxone is the definitive treatment for opioid overdose, the immediate priority for a patient with inadequate or absent breathing is to support ventilation, often with a bag mask device, to provide oxygen and prevent further hypoxia. Administering naloxone is important and should follow, but ensuring adequate breathing is paramount. Always prioritize maintaining oxygenation and ventilation before administering medication. Question 19. What is the most common cause of cardiac arrest in infants and children? A. Cardiac arrhythmias. B. Respiratory arrest. C. Trauma. D. Sepsis. Answer: B. Respiratory arrest. This question tests a fundamental difference between adult and pediatric cardiac arrest. The keywords most common cause of cardiac arrest in infants and children are crucial. Unlike adults, where cardiac arrest is most often due to a primary cardiac event, in children, it typically results from progressive respiratory failure or shock that leads to respiratory arrest, followed by cardiac arrest. This is why ventilations are often emphasized early in pediatric resuscitation. Focus on breathing for children, as it's usually the root cause. Question 20. What is the recommended method for confirming proper placement of an endotracheal tube in a patient during cardiac arrest? A. Auscultation of breath sounds. B. End-tidal carbon dioxide, EtCO2, detection. C. Chest rise and fall. D. Visualization of the tube passing through the vocal cords. Answer: B. End-tidal carbon dioxide, EtCO2, detection. This question emphasizes the most reliable method for confirming advanced airway placement in an emergency. The keywords confirming proper placement and endotracheal tube point to the definitive method. While auscultation, chest rise, and direct visualization are important adjuncts, continuous quantitative waveform capnography, measuring EtCO2, is the most reliable method for confirming and continuously monitoring endotracheal tube placement during cardiac arrest. A persistent waveform indicating CO2 exhalation confirms the tube is in the trachea, not the esophagus. Rely on capnography for tube confirmation. Question 21. What is the initial recommended treatment for a patient with stable monomorphic ventricular tachycardia with a pulse? A. Defibrillation. B. Amiodarone. C. Synchronized cardioversion. D. Atropine. Answer B. Amiodarone. This question differentiates treatment approaches for tachycardias based on stability and rhythm morphology. The key phrase stable monomorphic ventricular tachycardia with a pulse indicates that the patient is not immediately crashing but has a potentially dangerous rhythm. For stable VT with a pulse, antiarrhythmic medications like amiodarone, procainamide, or sotalol are the initial recommended treatments, aiming to convert the rhythm or slow it down. Synchronized cardioversion is reserved for unstable tachycardias, while defibrillation is for pulseless rhythms. Start with medication for stable VT with a pulse. Question 22. What is the recommended dose of intravenous magnesium sulfate for a patient in torsades de pointes? A. 1 gram 4. B. 2 grams 4. C. 3 grams 4. D. 4 grams 4. Answer B. 2 grams 4. This question tests your knowledge of specific pharmacological interventions for particular arrhythmias. The keyword torsades de pointes, a polymorphic ventricular tachycardia associated with prolonged QT interval, directly points to magnesium sulfate as the treatment. The recommended dose of intravenous magnesium sulfate for torsades de pointes, whether the patient has a pulse or is pulseless, is 1 to 2 grams, typically 2 grams, diluted and administered over 5 to 20 minutes, or as a rapid bolus if pulseless. Magnesium helps stabilize cardiac electrical activity in this specific condition. Question 23. A patient is in cardiac arrest due to suspected hypothermia. What is a key consideration regarding defibrillation in this scenario? A. Defibrillation should be avoided until the patient is warmed. B. Only one defibrillation attempt should be made. C. Defibrillation is only effective once the core temperature is above 90 degrees Fahrenheit 30 degrees Celsius. D. Defibrillation should be attempted up to 3 times, then deferred until core temperature rises. Answer D. Defibrillation should be attempted up to 3 times, then deferred until core temperature rises. This question addresses specific considerations for managing cardiac arrest in special circumstances, specifically hypothermia. The keywords suspected hypothermia and defibrillation are important. In hypothermic cardiac arrest, defibrillation may be ineffective at very low core body temperatures. The guideline suggests attempting defibrillation up to 3 times. If unsuccessful, further attempts should be deferred until the patient's core temperature rises above 86 degrees Fahrenheit 30 degrees Celsius, while continuous CPR and rewarming efforts continue. This pragmatic approach balances the need for electrical therapy with its potential ineffectiveness in extreme cold. Question 24. A patient has return of spontaneous circulation, ROSC, after cardiac arrest. What is the target partial pressure of arterial carbon dioxide, PaCO2, range during post-cardiac arrest care? A. 25 to 30 millimeters of mercury. B. 35 to 45 millimeters of mercury. C. 50 to 60 millimeters of mercury. D. greater than 60 millimeters of mercury. Answer B. 35 to 45 millimeters of mercury. This question evaluates your understanding of optimal ventilation targets in post-cardiac arrest care. The key terms are ROSC, target partial pressure of arterial carbon dioxide, PaCO2, range, and post-cardiac arrest care. After ROSC, maintaining normocarbia, normal CO2 levels, between 35 to 45 millimeters of mercury is crucial to optimize cerebral blood flow and prevent secondary brain injury. Both hypocapnia, too low CO2, and hypercapnia, too high CO2, can be detrimental. Aim for normal CO2 levels to protect the brain after ROSC. Question 25. Which of the following is considered a non-shockable rhythm in the adult cardiac arrest algorithm? A. Ventricular fibrillation, VF. B. Pulseless ventricular tachycardia, private. C. Asystole. D. Ventricular tachycardia with a pulse. Answer C. Asystole. This question tests your ability to distinguish between shockable and non-shockable cardiac arrest rhythms. The keyword non-shockable rhythm is central. Asystole, which appears as a flat line on the ECG, signifies complete absence of electrical activity in the heart and is a non-shockable rhythm. Ventricular fibrillation, VF, and pulseless ventricular tachycardia, private, are shockable rhythms where defibrillation is indicated. Ventricular tachycardia with a pulse is a tachycardia algorithm, not a cardiac arrest rhythm. Remember, for asystole, focus on CPR and epinephrine, not defibrillation. Question 26. What is the recommended intervention for a patient with an unstable tachycardia, e.g., VT with pulse, AF with RVR, causing signs of shock or acute heart failure? A. Administer adenosine. B. Perform immediate synchronized cardioversion. C. Administer amiodarone. D. Perform CPR. Answer B. Perform immediate synchronized cardioversion. This question assesses your knowledge of the immediate management of unstable tachycardias. The keywords unstable tachycardia and causing signs of shock or acute heart failure indicate that the patient is hemodynamically compromised. In such critical situations, immediate synchronized cardioversion is the treatment of choice to rapidly restore a stable rhythm and resolve the instability. Medications like adenosine or amiodarone are for stable tachycardias, and CPR is for pulseless rhythms. When unstable, shock them back to normal. Question 27. What is the typical initial dose of adenosine for a patient with stable narrow-complex supraventricular tachycardia, SVT? A. 3 mg 4 bolus. B. 6 mg 4 bolus. C. 12 mg 4 bolus. D. 1 mg 4 bolus. Answer B. 6 mg 4 bolus. This question specifically tests your knowledge of the initial dose of adenosine. The keywords initial dose of adenosine and stable narrow-complex supraventricular tachycardia, SVT, indicate the exact scenario. For stable SVT, the first dose of adenosine is 6 mg administered as a rapid 4 bolus, followed by a flush. If the SVT persists after 1 to 2 minutes, a second dose of 12 mg may be given. Remember that 6 mg is the standard starting dose for adenosine. Question 28. During CPR, what is the target compression rate for adults? A. 60 to 80 compressions per minute. B. 80 to 100 compressions per minute. C. 100 to 120 compressions per minute. D. 120 to 140 compressions per minute. Answer: C. 100 to 120 compressions per minute. This question focuses on another critical component of high-quality CPR, the compression rate. The keyword target compression rate for adults is key. A rate of 100 to 120 compressions per minute ensures adequate blood flow to vital organs during cardiac arrest. Compressions delivered too slowly or too quickly can be less effective. Always strive for a rhythm that's staying alive fast. Question 29. What is the recommended post-cardiac arrest management strategy for patients who remain comatose after ROSC? A. Immediate discharge home. B. Therapeutic temperature management, TTM. C. Aggressive fluid resuscitation. D. Immediate surgical intervention. Answer: B. Therapeutic temperature management, TTM. This question tests your knowledge of advanced post-cardiac arrest care. The key phrases are post-cardiac arrest management strategy, comatose after ROSC, and recommended. Therapeutic temperature management, TTM, formerly known as therapeutic hypothermia, is a critical intervention for comatose patients after cardiac arrest to improve neurological outcomes and survival. It involves maintaining a target temperature, typically 32 to 36 degrees Celsius, for at least 24 hours. TTM is a cornerstone of advanced post-cardiac arrest care for patients who don't wake up immediately. Question 30. What is the primary purpose of assessing pulses and checking for signs of circulation, e.g., responsiveness, breathing, in an unresponsive adult? A. To determine if the patient has hypertension. B. To identify if cardiac arrest is present and initiate CPR. C. To assess for signs of stroke. D. To determine the patient's fluid status. Answer: B. To identify if cardiac arrest is present and initiate CPR. This question addresses the fundamental initial assessment in an unresponsive patient. The keywords primary purpose, assessing pulses, and unresponsive adult lead to the core decision-making step. The rapid assessment for a pulse and signs of circulation, or lack thereof, is crucial to quickly determine if the patient is in cardiac arrest and whether chest compressions are immediately needed. If there's no pulse or normal breathing, it's time to start CPR. Question 31. What is the recommended dose of atropine for symptomatic bradycardia? A. 0.25 mg for. B. 0.5 mg for. C. 1 mg for. D. 2 mg for. Answer: B. 0.5 mg for. This question specifically tests the dosage of a commonly used medication for symptomatic bradycardia. The keywords recommended dose of atropine and symptomatic bradycardia are essential. The initial dose of atropine for symptomatic bradycardia is 0.5 mg administered intravenously, and may be repeated every 3 to 5 minutes for a maximum total dose of 3 mg. This dose helps to increase the heart rate by blocking parasympathetic vagal stimulation. Question 32. What is the most critical initial intervention for a patient experiencing an acute stroke? A. Administration of nitroglycerin. B. Rapid transport to a stroke center. C. Administration of intravenous fluids. D. Immediate intubation. Answer: B. Rapid transport to a stroke center. This question emphasizes the time-sensitive nature of stroke management. The key phrases most critical initial intervention and acute stroke highlight the need for immediate, specialized care. For acute stroke, rapid recognition and transport to a stroke center capable of performing brain imaging, like a CT scan, and administering thrombolytics, like TPA, or performing thrombectomy is paramount. Time lost means brain lost, so getting to the right facility quickly is vital. Question 33. A 55-year-old male presents with crushing chest pain, diaphoresis, and shortness of breath. What is the first medication generally administered in the field for suspected acute coronary syndrome, ACS, assuming no contraindications? A. Morphine. B. Oxygen. C. Aspirin. D. Nitroglycerin. Answer: C. Aspirin. This question focuses on the initial pharmacological management of suspected acute coronary syndrome, ACS. The keywords first medication, suspected acute coronary syndrome, ACS, and no contraindications are important. Aspirin is typically the first medication given because it inhibits platelet aggregation, reducing clot formation and limiting infarct size in ACS. While oxygen and nitroglycerin are also important, aspirin is the immediate antiplatelet therapy. Always think A4 aspirin as the first medication for suspected ACS. Question 34. In the adult cardiac arrest algorithm, what is the primary distinction between managing a shockable rhythm, VF/private, and a non-shockable rhythm, asystole/PEA? A. The use of chest compressions. B. The administration of epinephrine. C. The indication for defibrillation. D. The timing of rhythm checks. Answer: C. The indication for defibrillation. This question highlights the core difference in treatment paths within the cardiac arrest algorithm. The keywords primary distinction and shockable rhythm, VF/private, and a non-shockable rhythm, asystole/PEA, point to the fundamental decision point. The main difference lies in whether defibrillation is indicated. VF and private are treated with immediate defibrillation, whereas asystole and PEA are not, and focus remains on CPR and identifying/treating reversible causes. All cardiac arrest rhythms receive chest compressions and epinephrine, but only shockable rhythms get defibrillation. Question 35. What is the recommended post-cardiac arrest systolic blood pressure target for adult patients? A. Less than 90 millimeters of mercury. B. At least 90 millimeters of mercury, and mean arterial pressure, MAP, at least 65 millimeters of mercury. C. 120 to 140 millimeters of mercury. D. Greater than 140 millimeters of mercury. Answer: B. At least 90 millimeters of mercury, and mean arterial pressure, MAP, at least 65 millimeters of mercury. This question addresses the goal of optimizing hemodynamics in post-cardiac arrest care. The keywords recommended post-cardiac arrest systolic blood pressure target and adult patients are crucial. Maintaining adequate cerebral and coronary perfusion is vital after ROSC. The target is to keep the systolic blood pressure at or above 90 millimeters of mercury and the mean arterial pressure, MAP, at or above 65 millimeters of mercury to ensure vital organ perfusion and prevent secondary injury. Always prioritize maintaining adequate blood pressure after ROSC. Question 36. What is the most appropriate action if a patient is experiencing symptomatic bradycardia and is unresponsive to atropine, but transcutaneous pacing, TCP, is unavailable or ineffective? A. Administer adenosine. B. Prepare for synchronized cardioversion. C. Consider dopamine or epinephrine infusion. D. Administer aspirin. Answer C. Consider dopamine or epinephrine infusion. This question tests your progression through the symptomatic bradycardia algorithm when initial treatments fail. The keywords symptomatic bradycardia, unresponsive to atropine, and TCP unavailable or ineffective lead to the next pharmacological options. If atropine is ineffective and TCP is not viable or working, the next step is to consider adrenergic infusions like dopamine or epinephrine to increase the heart rate and improve the patient's hemodynamic status. These medications provide chronotropic and inotropic support. Question 37. When preparing for defibrillation, what is the crucial safety step to ensure the safety of the rescuer and others? A. Ensure the patient is dry. B. Shout all clear. C. Apply conductive gel. D. Check the patient's blood pressure. Answer B. Shout all clear. This question highlights a fundamental safety aspect of defibrillation. The keywords crucial safety step and defibrillation are important. Before delivering an electrical shock, it is absolutely essential to verbally clear all personnel from contact with the patient, the bed, and any equipment connected to the patient. Shouting all clear confirms that everyone is safely away, preventing accidental electrical shock to rescuers or bystanders. Patient safety is paramount during defibrillation. Question 38. What is the initial recommended defibrillation energy dose for ventricular fibrillation, VF, using a biphasic defibrillator? A. 50 to 100 J. B. 120 to 200 J. C. 200 to 300 J. D. 360 J. Answer B. 120 to 200 J. This question specifically asks about the initial energy dose for biphasic defibrillators, which is different from monophasic. The keywords initial recommended defibrillation energy dose, ventricular fibrillation, VF, and biphasic defibrillator are critical. For biphasic defibrillators, the initial energy dose for VF/private is typically 120 to 200 joules, with subsequent escalating doses if the first is unsuccessful. The exact range can vary slightly by device manufacturer, so follow the specific recommendations on the device. Remember that biphasic uses lower energy settings than monophasic defibrillators. Question 39. A patient is unresponsive, apneic, and has a palpable carotid pulse of 40 bpm. What is the most appropriate initial intervention? A. Start chest compressions. B. Administer 1 mg epinephrine. C. Administer atropine 0.5 mg for. D. Begin assisted ventilations. Answer D. Begin assisted ventilations. This question tests your ability to differentiate between cardiac arrest and severe respiratory compromise with a pulse. The key elements are unresponsive, apneic, not breathing, and palpable carotid pulse of 40 bpm. Since the patient has a pulse, cardiac arrest is not present yet, but severe respiratory compromise is. The immediate priority is to address the breathing problem by providing assisted ventilations, e.g., with a bag mask device, to oxygenate the patient and prevent progression to cardiac arrest. Start breathing for them, not chest compressions, if a pulse is present. Question 40. Which of the following is a key component of effective team dynamics during a resuscitation attempt? A. Individual decision-making without group input. B. Clear roles and responsibilities. C. Avoiding direct feedback to prevent offense. D. Waiting for a physician to arrive before initiating care. Answer B. Clear roles and responsification. This question focuses on the behavioral aspects of a successful resuscitation. The keyword key component of effective team dynamics highlights the organizational structure. Clear roles and responsibilities ensure that every team member knows their specific tasks, avoiding duplication of effort or missed interventions. This promotes efficient and coordinated care, which is crucial during high-stakes emergencies like cardiac arrest. Good teams have a clear playbook. Question 41. After ROSC, a patient develops generalized tonic-clonic seizures. What medication might be considered to manage these seizures? A. Atropine. B. Lidocaine. C. Benzodiazepines, e.g., midazolam or lorazepam. D. Adenosine. Answer: C. Benzodiazepines, e.g., midazolam or lorazepam. This question delves into managing complications in post-cardiac arrest care. The key phrases are after ROSC, generalized tonic-clonic seizures, and medication to manage. Seizures are a common neurological complication after cardiac arrest and are detrimental to brain recovery. Benzodiazepines like midazolam or lorazepam are first-line agents used to treat post-anoxic seizures because of their rapid onset and anticonvulsant properties. Controlling seizures is vital for neuroprotection. Question 42. What is the initial intervention for a patient with pulseless electrical activity, PEA? A. Defibrillation. B. Administer adenosine. C. Start chest compressions and administer epinephrine. D. Synchronized cardioversion. Answer: C. Start chest compressions and administer epinephrine. This question tests your management of a non-shockable cardiac arrest rhythm. The keyword pulseless electrical activity, PEA, identifies the rhythm. PEA is a cardiac arrest rhythm where there is organized electrical activity on the ECG but no palpable pulse, and it is a non-shockable rhythm. The immediate intervention is to begin high-quality chest compressions and administer epinephrine, while simultaneously focusing on identifying and treating the underlying reversible causes, H's and T's. Remember, PEA means push epinephrine and find the cause. Question 43. What is the recommended compression depth for children during CPR? A. At least 1 inch 2.5 centimeters. B. At least 1.5 inches 3.8 centimeters. C. At least 2 inches 5 centimeters. D. Approximately 2 inches 5 centimeters or 1/3 the AP diameter of the chest. Answer: D. Approximately 2 inches 5 centimeters or 1/3 the AP diameter of the chest. This question focuses on pediatric CPR guidelines, specifically compression depth. The keywords recommended compression depth and children are crucial. For children, the recommended compression depth is approximately 2 inches 5 centimeters or about 1/3 the anterior-posterior, AP, diameter of the chest, whichever is less. This ensures effective compressions while preventing excessive force that could cause injury. Remember the 1/3 the chest diameter rule for children. Question 44. A patient is experiencing severe chest pain and their 12-lead ECG shows ST segment elevation. They have no contraindications to thrombolytic therapy. What is the maximum acceptable time from first medical contact, FMC, to administration of fibrinolytic therapy if PCI is not available? A. 30 minutes. B. 60 minutes. C. 90 minutes. D. 120 minutes. Answer: A. 30 minutes. This question addresses the critical time targets in STEMI management when percutaneous coronary intervention, PCI, is not immediately available. The keywords ST segment elevation, no contraindications to thrombolytic therapy, and maximum acceptable time from first medical contact, FMC, to administration of fibrinolytic therapy are vital. If primary PCI cannot be performed within 120 minutes of first medical contact, fibrinolytic therapy should be administered within 30 minutes of hospital arrival. This door-to-needle time of 30 minutes is crucial for reperfusion and improved outcomes. Time is muscle, and these timelines save lives. Question 45. What is the recommended treatment for a responsive patient exhibiting symptoms of an acute stroke with a blood glucose level of 40 mg per deciliter? A. Administer aspirin. B. Administer intravenous dextrose. C. Perform immediate CT scan. D. Prepare for thrombolytic therapy. Answer: B. Administer intravenous dextrose. This question tests your ability to identify and manage stroke mimics, specifically hypoglycemia. The key phrases are responsive patient exhibiting symptoms of an acute stroke and blood glucose level of 40 mg per deciliter, which is significantly hypoglycemic. Stroke-like symptoms can be caused by severe hypoglycemia, and correcting the low blood sugar with intravenous dextrose is the immediate priority, as it can often resolve the neurological deficits. Always check blood glucose levels in suspected stroke patients, as hypoglycemia is a treatable mimic. Question 46. During resuscitation efforts, what is the role of capnography, ETCO2 monitoring? A. To measure blood pressure. B. To assess the quality of chest compressions and confirm tracheal intubation. C. To determine core body temperature. D. To diagnose myocardial infarction. Answer: B. To assess the quality of chest compressions and confirm tracheal intubation. This question highlights the multifaceted utility of capnography in resuscitation. The keyword role of capnography, ETCO2 monitoring, points to its diagnostic and monitoring capabilities. Continuous quantitative waveform capnography is critical because it confirms and monitors endotracheal tube placement, and also provides a real-time indicator of the effectiveness of chest compressions. A sudden rise in ETCO2 can also indicate ROSC. It's a powerful tool for monitoring CPR quality and patient status. Question 47. A patient in cardiac arrest receives 1 mg of epinephrine. What is the typical timing for the next dose if cardiac arrest persists? A. In 1 minute. B. In 3 to 5 minutes. C. In 10 minutes. D. Only after defibrillation. Answer: B. In 3 to 5 minutes. This question tests your knowledge of the frequency of epinephrine administration in cardiac arrest. The keywords next dose, epinephrine, and cardiac arrest persists are important. Epinephrine is administered every 3 to 5 minutes during cardiac arrest regardless of the rhythm, as it is designed to improve coronary and cerebral perfusion pressure. This consistent dosing ensures continuous pharmacological support throughout the resuscitation attempt. Question 48. What is the most appropriate first action for a nurse who discovers a patient unresponsive and pulseless in their hospital bed? A. Call the attending physician. B. Activate the emergency response system, e.g., code blue. C. Begin administering 4 fluids. D. Obtain a 12-lead ECG. Answer: B. Activate the emergency response system, e.g., code blue. This question assesses the immediate, foundational action in a medical emergency within a healthcare setting. The scenario describes an unresponsive and pulseless patient in a hospital bed, highlighting a potential in-hospital cardiac arrest. The most appropriate first action, after confirming unresponsiveness and pulselessness, is to immediately activate the emergency response system, often a code blue, to bring trained personnel and equipment to the bedside to initiate full resuscitation. Getting help quickly is the priority. Question 49. A patient with symptomatic bradycardia unresponsive to atropine now has a second-degree AV block type 2 on the ECG monitor. What is the most appropriate next intervention? A. Administer another dose of atropine. B. Prepare for transcutaneous pacing, TCP. C. Administer adenosine. D. Give intravenous fluids. Answer: B. Prepare for transcutaneous pacing, TCP. This question challenges your understanding of the bradycardia algorithm's progression. The key phrases are symptomatic bradycardia, unresponsive to atropine, and second-degree AV block type 2. Atropine is less likely to be effective for type 2 AV block or third-degree AV block because the block is typically below the AV node. Therefore, if atropine fails, the next step for symptomatic bradycardia, especially with these higher-degree blocks, is to prepare for or initiate transcutaneous pacing, TCP, to electrically stimulate the heart and increase the rate. Question 50. What is the purpose of post-cardiac arrest debriefing for healthcare teams? A. To assign blame for poor outcomes. B. To review patient billing and insurance. C. To identify strengths and areas for improvement in team performance. D. To determine future shift schedules. Answer: C. To identify strengths and areas for improvement in team performance. This question focuses on the importance of quality improvement and learning in resuscitation. The keyword purpose of post-cardiac arrest debriefing is crucial. Debriefing sessions allow the healthcare team to review the resuscitation attempt, discuss what went well, identify areas where improvements can be made in individual performance or team dynamics, and learn from the experience. This process is essential for continuous improvement in patient care and team effectiveness, not for assigning blame or administrative tasks.